mainly in general, the risk factors related to suicide, and the most important ones are gender, being a male, having older age or a middle age, having a history of suicide in the past, having family history of suicide, having psychiatric illness, medical illness, and history of aggression. But divided into personality, cognitive, so personality factors having feelings of hopelessness, having aggression, or having impulsivity. In cognitive factors, it will be more like being very rigid, having thought suppression, and history also as well of agitation. In social risk factors will be being isolated from people, and also having negative childhood events or any history of physical or sexual trauma. And for positive factors will be having a good support system, having resilience, optimism, having if there's a patient with psychiatric illness or mental illness, to have access to care, and having a skill for problem solving. For example, if you have a patient, if you do a good evaluation and you find out that the patient is depressed, or it has bipolar disorder, or has any history of substance abuse, you can treat it. So in that way, decreases the risk of suicide. And also, for example, if you notice that the patient doesn't have any social support at home, maybe you can link the patient with community services. And also, it's important that the patient has at least has a good therapeutic alliance with because it will be more also a support system. Any changes from patient's baseline, for example, changes in behavior, changes in appetite, changes in the patient's mood, and also if the patient has a psychiatric illness and there is any decompensation from this, or the patient is not in care, if there is a patient with substance abuse, as I mentioned, if there's like aggression, agitation, or any anxiety, or anything that it's different from the normal, or of course that the patient start talking about suicide, that the patient talks about having a plan. So those are the main warning signs. So if the patient, you did your suicide risk assessment and it looks like the patient still have a ongoing suicidal ideation, if the plan it's very lethal, if there is no social support, so when you discharge the patient, there's no one that will be around of the patient, especially in the child and adolescents. Also, if there's no way to do a good outpatient treatment plan, and if the patient has a psychiatric illness and it decompensated, so you will need to admit it in order to control it, and if there's aggression, or the patient is not able to discuss about what is going on, is kind of avoidant to discuss about what is going on. So, well, it depends when the patient start talking about it, because if the patient is not talking about it, and as mentioned before, if the patient, there's a lot of patients with chronic suicidal ideation, but not with no intent or a plan. So it's important to assess that if there is a plan, there's an intent to go after these thoughts. So that's the main thing. And usually that's more than when with chronic suicidal ideation with no intent. Mostly it's therapy. So the patient will benefit more, of course, treatment as well, but also being in therapy. Females or male can have suicidal thoughts, but usually females attempt more, but males usually have more lethals. Lethal means so they actually commit suicide. Kids start talking about suicide, to go to it's okay, go to primary care, psychiatry, whatever is available, because sometimes there is no availability to get a psychiatrist to be assessed and see if there's something else going on. The National Suicide Prevention Line, or you can go online to www.suicidepreventionlifeline.org, or calling 8255.